Hello everyone, welcome back to A to Z Dentistry, a channel which features easy explanation of various dental related topics, mnemonics, SAQs and LAQs for your exams. So today we'll be discussing about causes of tooth impaction. So without any further delay, let's get started. So these are our contents for today. Firstly, we'll see at the definition of tooth impaction. Then we'll have a look at the local causes of tooth impaction, followed by systemic causes of tooth impaction. So let's move on towards the definition. So impacted tooth basically is a tooth which is either completely or partially unerupted. Right now, by the word unerupted, we means that this particular tooth hasn't reached its position, that is, it hasn't reached its occlusal plane yet, right? Therefore it is called as unerupted, and it is positioned against any another tooth. For example, if we talk about impacted wisdom tooth, then definitely it is positioned against the second molar, right? So therefore in this case our impacted wisdom tooth is positioned against second molar, or it can be positioned against a bone. Now imagine a situation wherein our wisdom tooth or the third molar is positioned towards the angle of the mandible, or rather the ramus of the mandible, right? That is, it is now positioned against a bone, or it can be positioned against a soft tissue, that is our gingiva, so that its further eruption is unlikely. Now as the tooth is positioned against any another tooth, bone or a soft tissue, it cannot erupt into the oral cavity, as these three or any of these three are acting as a barrier. They are preventing the eruption of the tooth into the oral cavity. Therefore its further eruption is unlikely, and this tooth is described according to its anatomical position. So it is necessary for us to describe this tooth according to its location, so that we can plan the treatment accordingly, and also we can discuss it with other dentists or maxillofacial surgeons, right, for the process of disimpaction. So these tooth are described according to their anatomic position. So again, OPG or panoramic radiograph describing multiple impacted teeth here, right, in the maxilla. As you can see, second molar, premolars, even the incisors are also impacted in this case, and in the lower arch also. Here one tooth is positioned within the ramus itself, that is in the coronoid region, right? Same thing, it is very near to the inferior border as well, and these radiolucencies are basically the cysts. So these cysts are surrounding the tooth, the crown of the tooth. So multiple impacted tooth as well as multilocular radiolucencies are present in this OPG. So basically this is a syndrome known as Gorlin-Gold syndrome, wherein there are multiple impacted teeth, and these are impacted mainly because of presence of odontogenic keratocyst, right? And these are creating a kind of multilocular radiolucencies. As here we can see, there are multiple radiolucencies present. So this is also a very important syndrome, and it can be asked in the MCQ, or an SEQ may be asked altogether, in which you will have to describe the clinical features, right? So let's move forward. So moving on towards the local and systemic causes of impaction, as in why the tooth or any tooth for that matter is prevented from reaching its position into the oral cavity or the occlusal plane, right? So there are two types of causes. We can divide the causes of impaction into either local causes, that means there are certain local factors which are preventing the eruption of tooth into the oral cavity, or there is some systemic condition, right? For example, cleidocranial dysplasia, it is a systemic condition wherein there are multiple impacted teeth. So we'll be discussing separately local causes as well as systemic causes. So these causes of impaction were first described by scientist Berger. So moving towards the local causes of impaction, the first one is irregularity in the position of the adjacent tooth, or if at all there is any kind of pressure being exerted by the adjacent tooth. Now what happens is that, for example, if we take into consideration the third molar, if there is any irregularity within the position of the third molar itself, it is positioned in an ectopic manner, right? As we call it ectopic tooth, it is positioned in a way which is not at all desirable, right? It is not in such a condition so that it can erupt into the oral cavity. Either it can serve as a local cause, or if the adjacent tooth right, is putting any kind of additional pressure onto the third molar. For example, if at all there is any pathology associated with the second molar, for example a growing and expanding cyst, so it might put amount of pressure on the third molar which might prevent its eruption into the oral cavity. Our second cause is density of the overlying bone or the surrounding bone. Now definitely we know that calcium is an important mineral which has a key role in eruption of the tooth, right? So what happens is that whenever there is increase in the density of the overlying bone or the surrounding alveolar bone, there is increase in the amount of mineralization of the bone, and the tooth is unable to come across that bone because it is not having enough pressure, right? For eruption into the oral cavity there has to be a certain amount of force, right? And this force and the amount of bone which is present should be more or less either equal, or the bone should be in such a manner that the amount of force via which the tooth is trying to erupt into the oral cavity, it may be able to pierce through that bone. So if at all there is any anomaly within the density of the bone, if at all there is increase in the density of the bone because of any impaired calcium metabolism, or for that matter any endocrine disorder is also present, it might prevent the eruption of the tooth, right? So this kind of things, whenever we talk about endocrinal cause, it will go into the systemic causes, whereas if we talk about locally, then we can mention density of the bone as an local cause of tooth impaction. So our third cause is localized chronic inflammation, right? Now as we know that during the process of inflammation there is attraction of WBCs into that area, right? Now because there is WBCs, there is dead and dying, then we have neutrophils and all other leukocytes, and because of that there is a edema which is present. Now because there is an edema, there is increase in the amount of pressure as well as there is increase in the density of the overlying mucous membrane. Now it may act as a soft tissue barrier for preventing the eruption of tooth into the oral cavity. So in this picture we can see that this is a classic example of soft tissue impaction, wherein the gum tissue is quite thickened, right? And because of that the third molar is unable to erupt into the oral cavity. So moving on, dilaceration is also an important local cause leading to impaction. What happens is that dilaceration is nothing but a sharp bend or a curve in the root, either at the apical area or the middle third, right? So basically whenever there is any anomaly within the root, what happens is that it might prevent the eruption of tooth into the oral cavity because of the irregularity in the shape of the tooth. Now this type of dilacerations occur in permanent dentition because there has been a trauma during the developmental stages. At the time where the tooth bud was developing, if the child meets with an accident or a traumatic force is imposed upon that tooth jump, it might lead to dilaceration in the permanent dentition. And dilaceration is very common in third molars as well, right? So this is also one of the cause for tooth impaction. Then over retained deciduous teeth. Now definitely in the definition itself we learned that if our tooth is positioned against any another tooth, now obviously if there is any over retained deciduous teeth, it may directly prevent the permanent teeth eruption into the oral cavity. Third is ectopic position of tooth bud. Now if the canine is placed at somewhere between the second premolar and molar region, because of the change in the environment, because of the change in the position itself, it may not be able to erupt into the oral cavity. So ectopic position of the tooth bud is also an important cause. Another cause is lack of space. Now as we know that as we are progressing towards the newer generations, the jaw size has been decreasing, right? So this creates an arch length tooth material discrepancy, right? The jaw is very small, so it won't be able to provide sufficient space for the tooth to erupt into the oral cavity. So simply because of the lack of space due to underdeveloped jaws, the tooth may not be able to erupt into the oral cavity. This is also a very common cause of impaction of third molar. Then another cause is obstruction, be it a soft tissue obstruction or a hard tissue. Under soft tissue, the obstruction may be due to a thick gingival biotype or because any chronic inflammation going on within the gum, or a chronic inflammation within the second molar. For example, if third molar is impacted, it may serve as a obstruction and prevent the eruption. Or it can be a hard tissue impaction, wherein either because of increase in the density of the bone, or because any overwritten tooth or position of third molar such that it is placed against the second molar. The second molar is indirectly acting as an obstruction for eruption of third molar into the oral cavity. So two types of obstructions, either hard tissue. In hard tissue we have obstruction due to bone or teeth, or it may be due to soft tissue, that is due to increase in the thickness of the gingiva. Moving on towards the systemic causes of impaction, right? So first we need to divide these causes into two types, that is either prenatal causes or postnatal. By prenatal we mean before birth, and by postnatal we mean after the birth. So certain factors, right, may lead to prenatal causes such as heredity, right? So if at all this, it is a familial trait wherein in the grandparents, then parents, and then child is also having impaction, then it might be that there is a heredity or a familial tendency for the same. Second is postnatal causes. Now these causes are mainly those which interfere with the development of the child. Now here, as we are dealing with systemic causes, so any cause or any disorder or a disease which is affecting the growth of the child in general will definitely affect the development of the teeth as well, right? So first one is rickets. Again, we have previously discussed about anomalies in calcium metabolism and how it can affect the eruption of the tooth. Same thing, rickets. Then we have anemia. Then syphilis, wherein we can see mulberry molars and screw-shaped incisors as well, right? Then we have tuberculosis, certain endocrinal dysfunctions. As we have discussed, endocrinal dysfunction directly affect the metabolism, right, of the bone, and it can lead to hard tissue impaction. Then malnutrition as well. If there is chronic deficiency of vitamin A, vitamin D, all these are very necessary for the ameloblast during the developmental stage as well, right? So if at all there is any deficiency of certain essential nutrients, then it might lead to impaction. So to remember this, you can simply remember it as RASTE. R for rickets, A for anemia, S for syphilis, T for tuberculosis, and E for endocrinal dysfunction. And it is very nice if you could remember malnutrition as well. Otherwise 5 causes are good. So in this picture we can appreciate that there is absence of canines and the laterals are also blocked out, they are buccally placed, right? So certain disorders which are affecting the health of the child in general can definitely affect the development of tooth. In the OPG again we can appreciate the same thing, right? There are impacted canines, these are blocked canines in the upper and in the lower as well, right? So these are systemic causes which directly or indirectly affect the growth of the child and thereby may lead to impaction. Apart from prenatal and postnatal causes, we can also classify systemic causes under rare condition. That is, these diseases are not very common per se, but if they are present, they are a bit of serious conditions wherein definitely we can find multiple impacted teeth. First one is cleidocranial dysostosis. As I have mentioned previously, it can definitely lead to multiple impacted teeth. Then we have oxycephaly, progeria, osteopetrosis, and cleft palate. Cleft palate, obviously there is decrease in the size of the palate itself, right? There is underdevelopment of the palatine processes, there is very less space for the tooth to erupt. So even if the tooth try to erupt, they will be in an ectopic position. Again, if at all, for example, if we say that the canine is in ectopic position or the second molar is in ectopic position, definitely it will create troubles for development for the eruption of third molar, directly or indirectly. So diseases like cleft palate definitely can lead to multiple impacted teeth. So to remember this, we can simply remember it as COOP or COP, double C double OP, right? C for we have cleidocranial dysostosis, then again C for we have cleft palate, osteopetrosis, oxycephaly, and P for progeria. So quite easy to remember. So in the first picture, it is an example of cleft palate, right? You can see that there is anomaly in the morphology of the palate itself, right? There is improper fusion of two palatine processes of the jaw, and that is leading to impacted lateral incisors, right? So the lateral incisors are being impacted because of the abnormality of the jaw itself. So again, cleft palate, a rare condition wherein because of the decrease in the size of the jaw itself or the underdevelopment of the palatine processes is preventing the eruption of the anteriors particularly. Again, next example is an again OPG, wherein we can see there are impacted canines, impacted incisors, again impacted premolars as well, in the upper as well as in the lower. Again, this is an example of a rare condition, progeria, wherein multiple impacted teeth are seen. Again here, type of mesoangular impaction, wherein because of the ectopic position of the third molar itself, there is resorption of the distal root of the second molar. Again, this is also a very common phenomenon. Whenever there is a mesoangular type of impaction of the third molar, it might lead to root resorption of second molar because of the pressure which the third molar is exerting on the roots of second molar, right? And this third molar is dilacerated as well, right? So again, first thing is its anomaly in the position. It is positioned well below the upper border of the mandible, right? Superior, this is our superior border of the mandible, and this I'll just use a pencil to mark this, right? So this is our superior border, right? And here this is our tooth. So because of this anomaly in the position, first thing is its location, right? So it is located far below the superior border, far below the occlusal surface, and its position. Second, its position. It is positioned against the root of second molar, right? So it is causing a mesoangular type of impaction here, right? And because of this, the pressure which the third molar is exerting, there is a resorption in the root of second molar, see. So this is the resorption. So this pressure has caused the resorption of the root of second molar. So you can see how a simple impacted tooth, if not treated timely, can lead to destruction of other teeth as well, right? So always, if you see a scenario wherein we are getting an impacted tooth, always ask the patient to get it removed, because even if it is not causing a trouble at that particular time, it may lead to troubles in the future. Either it might get associated with a cyst, or due to improper hygiene, some other pathology, then again it might cause resorption of another tooth or some other problems, right? So definitely ask your patient to get impactions treated. Moving on towards the last part of our video, that is the mnemonics, right? So we have discussed two mnemonics in this video. Under systemic causes, we have discussed RASTE as a mnemonic for rickets, anemia, syphilis, tuberculosis, and endocrinal dysfunctions as postnatal causes of tooth impaction. Then we have discussed COP, CCOOP, for rare conditions leading to impaction: cleidocranial dysostosis, cleft palate, oxycephaly, osteopetrosis, and progeria. Right? So I hope you have understood this topic very well. So very briefly, this was all about local causes as well as systemic causes of tooth impaction. I hope you understood this topic well. This is Dr. Snehal signing off. Bye bye. Take care.